Hi, my name is Lipika Goyal. I'm an instructor at Harvard Medical School and I'm a hepatobiliary oncologist. I spoke today about FGFR fusion-positive intrahepatic cholangiocarcinoma. Cholangiocarcinoma is a rare disorder of the bile ducts in the liver, and unfortunately it has a poor prognosis in the advanced stages where people live about 1 year. And in 2010, we figured out that 2 chemotherapies, gemcitabine and cisplatin, help patients with this disease. But since then, we have not been able to find any other drugs to be approved. But the good news is there's promise with the genomic revolution because we have found FGFR2 fusions in about 10 to 15% of patients, and it looks like a promising target. What we have seen is that when we give people FGFR inhibitors that are selective and they have this fusion, about 25% of patients have significant tumor reduction, and about 83% of patients have some benefit from the drug. That's really encouraging because with chemotherapy alone, only about 5 to 10% of patients have shrinkage. Unfortunately though, what we're finding is that while people have benefit, the benefit is not as long as we want it to be. It's only about 6 months or so. So one of the things that we've been doing is looking at resistance to these drugs, and it's an integrated effort with several investigators at MGH, including Ryan Corcoran, Nabil Bardisi, Andrew Zhu, and Dan Urich. And we're looking at why people are rapidly developing resistance to these drugs. And we've found that people are developing mutations in the FGFR2 kinase domain, and that these mutations can be overcome with a next generation FGFR inhibitor called TAS-120. TAS-120 is currently in a phase 1 trial, and we have it here at MGH and at several centers around the country and the world. And it's a covalently binding FGFR inhibitor that has shown to overcome resistance now in a few patients who were previously treated with another FGFR inhibitor. We're also looking at why people are developing resistance to TAS-120, and that's some of what we discussed in the talk today. One patient developed a novel mutation in the cysteine residue that the drug binds to. So overall, we think that it's good to follow patients with serial circulating tumor DNA analysis and biopsies, and when possible, do a rapid autopsy after they pass to really understand what are the resistance mechanisms people are developing to this class of drugs, so we can help patients have more durable and more long-lasting responses.